Welcome and hello. This is our first episode in the series that we are calling Realities of Real World Evidence. Before we begin, just a little bit of introduction. As we know, the relevance of real world data and real world evidence in healthcare has been growing phenomenally. And as happens with most emerging concepts and avenues, there's a lot of discussion about it in all types of media, social media, industry forums, as well as scientific and trade journals. Actu-Real, while trying to provide innovative solutions to healthcare access challenges in this space, has experienced and has been dealing with challenges of how to access real-world data, how to use real-world evidence, etc. Hence, we thought it would be interesting to unravel the reality behind the hype that is generated by real-world evidence. So we decided to speak with a few leaders from medical teams of pharma companies in the first phase of this series of short interviews and podcasts. We will get their perspective on certain aspects of this trend and how it's playing out across various geographies that are in their scope and across their stakeholders. It's a privilege to have Dr. Viraj Suvarna as our first guest for this series. We have had several interesting discussions with him on this topic over the past decade or so and have also done some work together. Viraj comes with rich experience of about 25 years. In his early part of the career, Dr. Viraj spent over a decade at Pfizer as part of the medical team and then had another long tenure as medical director at Boehringer Ingelheim. After a few other companies that he worked with, he is now the medical chapter lead and chief medical officer at Roche. Welcome, Viraj, to this inaugural episode of the series, and thank you very much for joining us today. Today, we would like to focus on the value of real-world evidence on the commercial side of pharma and in an emerging market like India. So before I ask my first question, would you like to say something?
So first of all, thank you very much, Chitra. It's an honor to actually be the first speaker in this series of, I like the topic also, the realities of real world evidence. And although, as you rightly said, I am the Chief Medical Officer ad interim at Roche, Pharma India. Today, whatever I would be sharing in terms of my responses to your questions would be in my personal capacity and need not necessarily reflect the views of the organization that I'm working for. That's the usual, it's appropriate to have such a disclaimer, but please feel free to ask me anything that, that you wish to, and I hope I'll be able to answer per your expectations and of course the expectations of people who are going to listen to this.
Yeah, okay, sure. So I just have a couple of questions. So my first question is that the availability of real world data and access to real world data in a country like India is still very limited. So how have you tried to deal with this challenge in your various capacities and still tried to generate real world evidence when needed?
Yeah, you're right. But at the same time, see, there are different forms of real world data. So for example, the simplest form, and that is something which always comes to us as requests from doctors through our field force, that the doctor has some experiential data in his usual or typical clinical practice, and he would like our help in converting that into evidence. Now, if the doctor is, for example, someone who has worked in good clinical research practice, preferably global studies, then naturally he also translates a little bit of that in his clinical practice, and then he probably documents that data in the right manner. So then what we typically do is get a good quality third party like a medical writing agency, and they in turn would send their medical writer, statistician, data analyst, and it's entirely between the two of them, the doctor and the agency. And then, of course, the most important thing is whether that doctor has really collected data in an organized manner. And if he has done so, and if there is some meaning that can be given to that data to convert it into information that is then publishable and presentable, then yes, then the same thing is converted into a manuscript, obviously reviewed and approved by the doctor, and eventually published. So that kind of real world data is the simplest, but where now we need to move towards, and that's what we are also trying to do, is to try and get, it's like, you think in terms of what the market really needs. And when I say market, I don't only mean from a commercial perspective, I mean from the unmet medical need of the market. So sometimes there is data that is already available. So one is the electronic health records. I agree, not in too many places in India, but it's definitely better than what it used to be. And the second is real world evidence generation. So that data doesn't exist, and now you need to design it prospectively. With the limitations, obviously you can't compare it to a randomized controlled clinical trial, but still in the real world, as we know, you can get what are called as comparable cohorts using statistical techniques like, for example, propensity score matching. And then if we prospectively design such studies, at least to some extent, the quality of that study goes up. So although in the hierarchy of evidence, something like real world evidence will be right at the bottom, not maybe at the absolute bottom, but somewhere lower down, one can still enhance the quality. Because see, all said and done, as we know, while the randomized controlled clinical trial clearly is right at the top, there are limitations, especially when you want to extrapolate data from there into the real world. And we know the differences between what happens in an RCCT and in the real world. But at the same time, even real world evidence is important. So the way I see it is the two complement each other. And increasingly, it is something that even the regulator is talking about. Of course, they haven't formalized it. And even marketing teams, but of course their ask or demand is slightly, different. So we in the medical team have to educate them in terms of, it's good to work with good quality agencies and to come up with good quality publications. It's not just this doctor has some data and let's go and publish it. So that part of, the education still needs to happen. Yeah.
Okay. So I think in summary, what you're saying is the experiential data of the doctors, and that's still, an important way of getting real world data and real world evidence. And then to whatever extent possible, trying to design and conduct real world studies, observational studies.
Yeah, I forgot to also add the fact that registries, so either disease-based or product-based sometimes. Yeah. So that's another way in which people look at real world. Plus, of late, people are also looking at, for example, a compassionate use program. Mm-hmm. Now there, obviously the doctor, it's not the company. Ultimately, it's between the doctor and his patient. We, of course, provide the drug free of cost as part of a COP, but if the doctor wishes to publish his experience and even present it to the regulator sometimes, then that is also another avenue which doctors on their own do it. And lastly, of course, while the regulator does expect companies in some cases to do a phase 4 interventional trial, sometimes the drug is approved for something which is very rare, like a tumor agnostic rare cancer, where if you do a typical phase 4 interventional trial, what happens is you can't really predict where these patients are going to eventually be, because everything is based on diagnosis, and these are rare mutations. So rather than that, what we are suggesting is, can we just do it as a real world kind of evidence generation activity, but we'll do it with the highest quality possible, as and when doctors diagnose such patients and then of their own volition decide to put that patient on this particular drug indicated for that tumor agnostic rare cancer. Naturally, the doctor can collect baseline data, follow through data, and then that data collated across the very few number of patients in the country who would have that condition can be then submitted to the regulator. So there are different other ways also where real world evidence can be looked at.
No, thanks for bringing up this point about rare diseases. I think that's very very important these days. My second question now is, and you briefly alluded to it while answering the first question, but can you just tell us how have you seen the interest of commercial teams evolve with respect to real world evidence, and how have you been attempted to influence their interest and their acceptance of real world evidence?
So, in a structured way, what happens is, before the year begins, there is this brand strategy that has to be co-conceptualized between the marketing and medical affairs individual. So that is when the medical person is supposed to put together a medical plan, and within that medical plan, sometimes would come, under the section of local clinical development projects, the need to have real world evidence generated, because that is the unmet medical need of the market. Sometimes, of course, but that is not planned for. But if doctors wish to have investigator-initiated studies, then that's another area where it is real world, generally. Now, as I told you earlier, marketing would look at more in terms of, product-related real world data generation. So if this doctor has prescribed a product on X number of patients, and that is kind of useful data for them because they feel that if this data is published, then that's real world. But at the same time, they need to understand that this is that doctor's data. So even if we were to facilitate it the way I described it earlier, we have to be firewalled from that process, which means we are also taking a risk that this data of that doctor, while he might say that this data is positive as far as your product is concerned, it is possible that out of, say, 10 patients, maybe 2 or 3, the outcome is not, as desired. And the way I see it, it is fine, because we need to present and publish the actual real world experience of that doctor. Although I know there would be limitations, because generally it's one arm and there's no control arm and things like that. But at least we need to understand that this particular product may not necessarily always have the desired outcome in all the patients. And that need not necessarily mean that the drug has some problem. It could be in terms of maybe the selection of the patient by that doctor, or the time of administration will be too late in the course of the disease. So all that could actually be the reason. And once that data gets shared in experience sharing meetings or even published, then doctors understand how to select the right patient for a particular product. And that's important because sometimes, people would always love to say my drug is better than another company's drug. But how I see it is, from a doctor's perspective, what he or she wants to know is, my patient, to which drug or regimen would he or she respond optimally? That is more important for me and my patient. So based on that, what companies can and should do is look into their own database, clinical trial database, and if possible, identify maybe baseline characteristics of patients, clinical and or biomarkers, and then try and correlate the same with the outcomes. So in some patients, optimal outcomes, both safety and efficacy. In some, safety, but not necessarily efficacy. In some, the opposite. And in some cases, even within the label of the product, there are patients who just don't respond. And we need to understand them also. So then, one could really educate the doctor. And so that eventually, I know we keep talking of this visual aid that the field force uses. Imagine if you could aid the doctor in visualizing the best patient profile for that particular product. Then the doctor knows. And if you tell him in which kind of patients it may not work, that also is good, because otherwise, we keep telling him where it'll work, or that please use the drug in all patients, and that doesn't really help. It's much better to admit that, in these patients, you can expect, there's a likelihood, a probability of good response. But in these kind of patients, perhaps even if it's within the label, it may not work. Then the credibility goes up. And then the doctor also understands that you're not in it just for yourself. You're in it for him and his patients. And I think that's a better way of promoting your product rather than, please use my product in all patients. So that is where I think real world can also help. Of course, in this case, it's about looking at clinical trial databases and coming up with these kind of correlations. But even when the experience of the doctor is shared, that is how other doctors will learn.
Yeah, and that's something, as part of the medical team, it's your responsibility to make the commercial team, marketing teams aware of the importance. Yeah. Good. Yeah, no, that's an interesting perspective. So, thank you very much, Dr. Viraj, for being here and for answering these questions and providing, some insights based on your experience. Thank you very much.
Thank you so much. Yeah.